you have to go, I'll start. Very good evening to all of you. At the outset, I would like to thank Director Sir for this initiative of Monthly Journal Club of Medical Education Unit and giving me this opportunity to be the first presenter. I would also like to express my gratitude to Sir for giving his consent to be the moderator of this session. Actually, the decision to start the journal club started on the online meeting of Medical Education Unit, which was held on 12th January. And it was the proactiveness of Sir that on the very same day, he mailed me 2 to 3 articles. From where I zeroed in this journal article, the title of which is Validity Evidence for Assessing Entrustable Professional Activities During Undergraduate Medical Education. And the first author is Claudio Violetto, and this was published in July 2021 issue of Academic Medicine. This is the official journal of Association of American Medical College, which is published at monthly interval, and it has a impact factor of 6.8. Well, the article starts with a background of a challenge of assessment in the competencies. Well, we all know that competence is a complex, interrelated, multidimensional construct to be acquired by the medical professional for safe and effective clinical practice. But the complexity in the definition and excessive granularity of its measuring aspects make competency assessment a challenge. But one potential solution to this challenge is the use of entrustable professional activities which provide a holistic approach to the competency assessment. Well, in Graduate Medical Education Regulation 2019 Gazette, we come across various terminologies like competencies, goals, roles, objectives, the competency domain, but the use of EPA is not there in this Gazette. So let us understand what is EPA. Entrustable professional activities are actually the units of professional practice. They are defined as tasks or responsibilities to be entrusted to the unsupervised execution by a trainee once he or she has attained sufficient specific competence. EPAs are independently executable, observable, and measurable in their process and outcome, suitable for entrustment decisions. So how do EPA differ from competencies? EPAs are not alternative for the competency, but they are a means to translate competency into the clinical practice. If competency are the descriptors of physicians, EPAs are the descriptors of work. EPAs usually require multiple competencies in an integrative, holistic nature. So EPAs provide a more concrete framework for assessors than the abstract, context-independent notion of competency, and thus they also provide an assessment framework with content validity evidence. The construct validity of EPA can be derived from the demonstration that growth of performance with experience follows a theoretically predictable pattern. So here comes the role of learning curves. And this was posited by Thurstone about 100 years ago. He posited that the relationship between the duration of practice and learning would be defined by a negative exponential function. Within the medical education, learning curves have application for both the individual as well as groups. So at the individual level, they illustrate the developmental trajectory for each student for different set of clinical skills. Whereas at the group level, they illustrate the length of time it takes the learners to attain a threshold level of knowledge or performance in executing a complex medical skill. So there are many uses of learning curves in the medical education. For example, it helps in making informed decision about the duration of program required for the learners to acquire a predefined competency level, how to use the educational resources efficiently to reach the individual and program goal, and how to enhance the curriculum, the teaching, assessment, and feedback to the learners. So with this background, the purpose of this article was to explore the validity evidence for the use of entrustable professional activities as an assessment framework in the medical education. Data that demonstrate learning curves for both individual learners and group of learners consistent with the negative exponential growth of learning provide validity evidence for the EPA framework. So authors here have analyzed the fit of learning curve models of negative exponential growth to the repeated measure of performance based on EPAs. So if we come to the methodology, the setting and participants, it was done in University of Minnesota Medical School, which was a part of four-site pilot project on EPAC. Now this EPAC stands for Education in Pediatrics Across the Continuum, which was designed to test the feasibility of advancement from undergraduate medical education to residency and from residency to fellowship or practice transition. And the competency in this pilot was defined by EPA framework of assessment using the core EPAs for UME to residency transition and the general pediatrics EPA for the residency to fellowship transition. And these are available in the website. So this study was exempted from review by the University of Minnesota. It was a multi-year, 4-year study, excuse me. The data came from formative assessment on 13 core EPAs collected from 14 students in 4 cohorts who participated in EPAC program during the academic year 2014-15 through academic year 2018 and 19. The number of students from the 4 cohorts were 4, 3, 3, and 4 respectively. So in this article, the entrustment level was defined as ability to perform a core EPA with indirect supervision, but here the supervisor had to check all the findings. We will understand these scales in subsequent slides. So this entrustment level corresponds to scale 5, which is also taken as a cutoff score because it signifies progression to a transition phase before residency. And the assessors were the faculty and residents who rated the student based on the direct observation while engaging in patient care together on a scale from 1 to 9, adapted from supervision scale published by Shane et al. So these are the 13 core entrustable professional activities, which was proposed by Association of American Medical College in 2014. So let us understand what are these EPA. One refers to that a trainee is able to gather a history and perform a physical examination. 2 is the trainee is able to prioritize a differential diagnosis following a clinical encounter. 3, recommend and interpret common diagnostic and screening test. 4, enter and discuss orders and prescriptions. 5 is that the trainee is able to document a clinical encounter in the patient record. 6 is to provide an oral presentation of a clinical encounter. 7, form clinical questions and retrieve evidence to advance patient. 8 is to give and receive a patient handover to the transition care responsibility. 9, collaborate as a member of interprofessional team. 10, recognize a patient requiring urgent or emergent care and initiate evaluation. 11, to obtain informed consent for tests and or procedures. 12, the trainee is able to perform the general procedures of a physician. And 13, identify the system failures and contribute to the culture of safety and improvement. So these are the supervision scale. In the original study by Shane et al., these scale ranged from 1 to 5, but in this study it has been translated into a scale from 1 to 9. So the scale 1 is the trainee is not allowed to practice EPA, not allowed to observe. But 2, the trainee is not allowed to practice EPA, but allowed to observe. 3 is allowed to practice EPA only under proactive, full supervision, co-activity with the supervisor. And 4 is the trainee is allowed to practice EPA only under reactive or on-demand supervision. Supervisor is ready in room to take over whenever required. 5, the trainee is allowed to practice EPA only under reactive and on-demand supervision available, but all the findings are doubly checked. Then in scale 6, it is the same, but here the supervisor doubly checks only the key finding, not the all findings. Then 7 is the trainee is allowed to practice EPA only under reactive and on-demand supervision. Supervisor is distantly available on phone. 8 is the trainee is allowed to practice EPA unsupervised. And 9 is the highest level where the trainee is able to supervise others in practice of EPA. So this is like a teaching level. So regarding the data analysis, the unit of analysis in this study was not the number of students, it was the number of observations. And the authors employed parametric analysis with entrustment rating scale, which is an ordinal scale similar to the widely used Likert scale. The students' rating were depicted as curves describing their performance over time. Regression models were employed to fit the curves, and the hierarchical regression analysis is mentioned in Appendix 1. I will just show it. The statistical power level of less than 0.05 required a minimum sample size equal to 84 observations. So the greatest limitation of the study comes here, where out of 13, only 6 EPAs were included in analysis because only these had 85 or more observations. So this is the appendix 1 showing hierarchical regression analysis. Now coming to the results of this study. So across the 4 years of this study, more than 2,400 total EPA-based assessments were made for 14 students. And visual display of these 6 EPAs growth over 10 months are presented as a learning curves in figure 1 and 2. We'll come to that. And as explained earlier also, a rating of 5 on the supervision scale was the cutoff score for entrustment. That is for transition phase to the residency. And this corresponds to the 3A level or the level 5, which is defined as the trainee is allowed to practice APA only under reactive or on-demand supervision available, but all the findings are doubly checked by the supervisor. So this is the figure A, which shows the EPA ratings of individual students over month. This shows a rapid learning of the students for all the EPAs, where they could reach the scale of 5. And the rating ranged from 2 to 9 for various EPAs, but the rating of 9 was achieved only on 2 occasions. That is for EPA 1, the trainee is able to gather history and do a physical examination, and one at sorry. Why this is not moving? So we can come to figure 2, which shows the theoretically fitted learning curves at group level with 95% confidence intervals. And these theoretically fitted curves suggest a curvilinear relationship, and the hierarchical regression analysis suggests that for all EPA, a curvilinear model was better fitted to the data than a linear model. So the frequent assessment of EPAs provided a developmental picture of competence consistent with the negative exponential learning curve theory. And this finding was true across a variety of EPAs and also for the students. The time taken to attain the threshold level of performance on EPA for entrustment varied by, for the student as well as according to the EPA. The cutoff for the entrustment level, that is a scale of more than or equal to 5, was achieved at 3 months for EPA 5 and 6, which was to enter the clinical encounter and also to give an oral presentation of the clinical encounter. And in 4 months for EPA 1 and 4, 5 months for EPA 2 and 3, and by 7 months, all the students had met or exceeded the cutoff score of equal to or more than 5, which was the entrustment level or the cutoff score. So coming to the discussion, the authors posited that the students' learning curves would follow Thurstone theory of negative exponential growth, and that doing so would provide the evidence of construct validity. So here both the raw data plotted over the time and the fitted curves did follow a negative exponential function. The negative exponential growth following a baseline performance demonstrated a latent phase to a maximal slope and subsequently decelerating growth in accordance with the theory. So this is the reference of the Thurstone learning curve equation, which was published about 100 years ago in 1919. Then this article also has a reference of this journal article, which was also published in Academic Medicine, the learning curves in health profession education. And here the learning curve is described as made up of a measure of learning across the y-axis and a measure of effort or practice across the x-axis. And it shows that at the individual level, the learning curves make manifest a single person's progress towards competence. The inflection point is the point where the learning becomes more effortful. This is the generic learning curve showing key properties where we can see the performance across the y-axis, the practice or effort across the x-axis, and this is the inflection point where the learning becomes more effortful. And this is the slope of maximum learning. So the study confirmed that some of the EPAs are more difficult to demonstrate performance at a predetermined level of competence than the others. The average time to attain the required level of competence for graduation varied between 3 to 5 months, depending upon the EPA. The origin of these differences may be related to some of the student factors, EPA factors, or the curricular factors. So let us see what were these factors. The student factors, the developmental trajectory suggested by the RIMS model, which refers to the reporter, interpreter, manager, and educator model. This was consistent with the author's finding. So EPAs that could match the reporter function, like the trainee or the student is able to do an oral presentation of a clinical encounter and also to document the clinical encounter. These were the first of the things which the students reached the threshold performance. And those requiring interpretation, like the student or the trainee is able to prioritize a differential diagnosis, or management aspects like the student or trainee is able to enter or discuss the orders and prescription, or he or she is able to recommend or interpret common diagnostic and screening test, requires a longer time frame to reach the same threshold. I really apologize for the poor visual quality of the slide, but this is the RIMS model of core APA, where the core APAs are actually presented or segregated into 4 things: the reporter functions, the interpreter function, the managerial function, and the educator function. So if out of 13 EPA which we discussed, if we split the EPA 3 and 10 into their interpreter aspect and the managerial aspects, the core EPA aligned with the RIMS model. And this contextualization has several benefits because the structures core EPA because it structures core EPA into a framework that is familiar to the medical educator, and it also organizes the EPA in the order they should be introduced, practiced, and entrusted. For example, the reporting, EPA related to the reporting, they should be introduced before interpreting. And the interpreter function should be introduced before manager, and similarly, the educator function should come at the last level. So this, again, I apologize the poor quality of the slide. The potential effect of contextualizing EPA with RIMS also helps in determining the stages of transition points, that is from pre-clerkship to clerkship, post-clerkship and internship level. So we discussed about the student factors. Now regarding EPA and curricular factors, the time to reach the threshold level of performance include the complexity and also the ease of observation. So tasks such as oral presentation are a part of workflow of almost every team. We do it every day. But observing a student performing history taking or doing a physical examination, it requires a pre-planning by the assessors. Student may enter the clerkship phase more practiced and assessed in some of the EPAs, such as oral presentation, than others, such as entering or documentation part of the clinical orders. So the progression of the student performance on the EPAs provide important information for the purpose of course design, instruction, and assessment. It appears to be more difficult for the students to meet or exceed the cutoff score of entrustment for EPA 2, which is to prioritize a differential diagnosis following a clinical encounter, and EPA 3, which is to recommend and interpret the common diagnostic and screening test. So it is reasonable to ensure that there is a sufficient time given to these EPAs, and also the curriculum, experiences, assessment, faculty development and feedback in these areas should be given sufficient time to allow for the competency to be achieved. Now, the limitation of the study was a small number of students, which was only 14. And another limitation was they did analysis on only 6 EPAs out of 13. But they had sufficient number of observation for regression analysis, because they made the number of observation as a unit of analysis rather than the number of students. And so they were, the authors were able to conduct multivariate regression analysis to develop the theoretically fitted curve. So coming to the conclusion derived from the study, the analysis of more than 2,400 assessment in EPAC programs, first 4 years of 4 EPAs 1 to 6, are consistent with the long-standing learning theory, and it provides the construct validity evidence for the EPAC's program of assessment. The students assessed using multiple observation performing the 4 EPAs for entering the residency demonstrate classical development progression towards the desired level of competence, resulting in entrustment decisions. However, future work with larger data sample will allow further psychometric analysis assessment of EPAs. So we should develop a passion for learning, because if you do, you will never cease to grow. So let us develop a passion of learning and understanding medical education. Thank you so much. And I look forward to Director Sir for his valuable comments and further explanation of this topic. Thank you.
Thank you, Dr. Archana. You have done a very good job. I think the first journal club, this has really set the standards quite high, and it will be good to carry on with this. First of all, I should say that journal club is just one of the activities which we should be doing under your medical education unit. It should be other kinds of activities should also go in parallel. So I have been circulating and circulated some of the papers which talk about how to make good multiple choice questions, what are the rules, and I think that can be discussed. Not as some of you wanted to do it as a journal club, but I have circulated for the purpose of doing it as more as a discussion to improve people's ability to make good multiple choice questions, which are called items in educational parlance. They call it items because one exam has multiple choice questions, and therefore each question is called an item for item analysis. That is why the word item is used. But basically, idea is how to make good questions. So those are that may be presented separately. Maybe Dr. Sandhya has volunteered to present it, maybe in one of the Fridays like this, not necessarily after 1 month, but whenever she is ready, she can make presentation. That is first point I wanted to make. The second point is that in USA, people are making, I would say, very sincere efforts to really implement competency-based medical education. And perhaps all of you know that it didn't start in India. It started actually in 1990s, even before that, in USA. And by 1990, there were already competencies defined for postgraduate medical education, which they call graduate medical education. So it started in postgraduate, what we call postgraduate, and Americans call graduate medical education. And they defined 6 competencies: patient care, medical knowledge, practice-based learning and improvement, system-based practice, ethics and professionalism, and one more, I think, interpersonal and professional interpersonal and communication skills. So these 5 competencies were defined way back in 1990 for residency program. And since that time, in residency, they are trying to implement it. And whenever I went to Canada or US, Canada has also adopted almost a similar thing. It's slightly different nomenclature, but it is the same thing. It's not that they were not struggling. They were struggling to really implement in true spirit, and people didn't know how to do it. So some of my friends in residency program in USA are program directors. The program directors were asked to implement it because graduate medical education will come and do inspection and grant recognition only if you have implemented this competency-based training. So it was not easy, and it has not been easy, and even now their struggle is ongoing. But gradually they have learned that it is not just one of measurement that you say competent, not competent, competency achieved, not achieved. So they developed what now they call entrustable professional activity. So they realized that it is not one-time thing; it grows over time. So obviously, you don't expect year 1 resident to go and if he is in surgery, he will start doing operation like laparoscopic cholecystectomy or anything like this. It has to be over the years that people will train. So that is where, after some deliberations, they developed what they call entrustable professional activity. It's not that we have not seen it. You know that when PG in our setup joins, obviously he will not do straight away nephrectomy or anything like this. They will first see whether he is able to open and close. So surgeons, they say they will like to see, observe, can you open the abdomen in front of me? And once they see that yes, they are able to do this, then they trust that resident that look here, You open, I'm coming to the operation theater, I'm in the ward, I will see 2 patients and come to you. So you go ahead, you start the process. First time they will only trust him just cleaning and just draping, cleaning and draping. Do it, I'm coming and I will start. Once they feel confident that they can do it, first they show them how to do it, then they observe them whether they can do it. So after they have done 1 or 2 times, they trust that resident to open. So first stage of EPA was just cleaning and draping. Second stage you can say is putting an incision and opening the abdomen. But still, in first go, they won't allow them to open the peritoneum, because after you open the peritoneum and you are not careful, intestine and other things will come up and they may cause perforation or something. So first, they will just allow them to go up to the peritoneum. Then maybe after they have seen several such surgeries, they will start trusting the resident to even open the peritoneum and go ahead to the next stage. So what I want to say is there are various stages where surgeon gradually trusts or entrusts the responsibility of doing different steps in a surgery to a resident. Same thing is what they are trying to do here, but now they have applied competency-based medical education in undergraduate. So that is where American Association of Medical Education has defined these 13 core EPAs, which means if a medical student has or can be trusted for these 13 core trustable professional activities, that means he is mature enough to become a resident. That is the idea.
Yes.
So this is why this is being done for undergraduate. The problem in India has been like this. We started in the reverse fashion, which is not correct. Actually, we should have started competency-based medical education in PG first, as Americans have done, because it is not easy to implement it in undergraduate, because in undergraduate, you don't trust practically any activity of patient care to the undergraduate student in India. In US, the clerkship is different. Anybody knows what is the clerkship structure in US?
Yes, sir.
So why don't you say it?
Sir, actually in US, it first starts, the clerkship first starts with the paperwork, documentation of the patient's records. And then you start touching the patients. So it is a gradual process.
Yeah, but what are the duties like for a student in US compared to the students' duties in India?
Sorry, I didn't get the question, sir.
What are the duties of students in the US when they are posted? Let's say you are posted for 2 months in medicine, for example.
Yes, sir.
You know what duties they have to do as compared to our setup.
Oh, that's what I knew, sir, that they first start with documentation only.
No. They have to do night duties. They are posted in the ward. They have to stay in the ward. They have to do once, sometimes almost whole week, every day night duties.
Yes, sir.
So
these are the roster duties they do say, there.
Yeah, and they are given patients that bed number 1 to 5 you are going to look after. So they are responsible for, that is why they call it clerkship. They are responsible for documenting everything which is happening in bed number 1, 2, 3, 4, and 5. So those documentation, the resident who are the postgraduates there, they will come and check that you have done it or not. They will also supplement some of the writings, or both students as well as residents will write. So they are doing duty just as a junior resident does here.
Yes, sir.
So that is where you have opportunity to observe how these students are performing, whether they can write well, whether they can take history, whether they can give history and present history and physical examination, whether they can give differential diagnosis, all of these things. But in India, is there any place where students are put on night duties and given charge of 1 or 5 beds?
No, sir.
No.
But
They just come and they are like as if they are like guests. They come and visit and just go around here and there, maybe see one case, take history, make presentation. There will be some discussion, case presentation, discussion, and go home. They are not to be seen in the afternoon. They are not to be seen in the evening. They have no night duty. They have no beds allotted to them, right? So I see that there will be great difficulty in, particularly in the clinical area, to decide about competency. So
Yes.
how many times you will assess each student, and what kind of if you are allotting patients to students and observing them in the round, they are there to present what happened in the night to this patient. They are almost like junior residents. But
Yes.
then you are able to observe them for days and days. So if they are posted for 2 months, 3 months, you are observing them. That is why out of 7 students, there are how many? 2,400 observations or something, right? So this is each observation is like filling up a form. So this is why they are able to do it. But how it will translate in our setting, because we haven't yet reached that level, but when it will reach, we will have difficulty in doing this because our setup is different. So what I would like to say is that we have to design our own kind of assessment. And good point in our situation is that we have large number of students. So over a period of 4 years, you want to study only 7 students, you will study maybe 70 or 80 or maybe 100 patients. So if Dr. Archana wants to study something in gynae, over a period of 4 years, he will get 180 or maybe more students posted to the gynae. So that is the plus point in our setup. We have large number of students, so we can think about our own situation and develop our own assessment system. And as you can see, that a study conducted on 7 students can be published in academic medicine. You may be knowing that academic medicine is only next to medical education in UK as a journal in medical education. The 2 top journals are medical education and academic medicine. So I don't know, impact factor of medical education used to be around 8. This one is around 7, but current situation, I don't know. So you can publish. This is another point I wanted to make, that if you design a study around students and do it, you can, and do a proper analysis, you can publish in best of the journals. So that is another message I would like to give. And think of these competencies and entrustable personal activity as if competency is like a 3-story building, and brick by brick you have to make, which ultimately will become 3-story building. Every floor when you reach is a milestone, and when you have a 3-story building, that is the competence. So think about entrustable professional activity like a brick. Each floor is like a milestone, and the whole building is like a competence.
So that was a very good analogy to understand.
Yeah, so think in that way, and if there are any questions, others can ask, no problem.
Sir, I had one doubt. Actually, how much I do understand about the journal club presentation it includes two parts. One is in short and about the main theme of the article, the first part. And in the second part, basically it is the critical appraisal. What is my viewpoints about it? And for this, there are many formats and templates are developed by different agencies like WHO and all. So we could have done this as a second part also, in
Yeah,
which
yeah.
what shortcomings are there in the article or what is very good. We could have done, because nowadays it has two objectives of journal
Yeah,
club
yeah.
presentation. One is making the students aware of the literature in current
Yes, yes.
scenario, and the second is developing their clinical skill or skill of critical appraisal also.
Yes, yes. But the scales which you are talking about, they are for clinical papers. There are some which are developing now for medical education papers, but they are not many. An educational journal article is of so many varieties that you will have to, because in clinical papers we have developed critical appraisal. My book is about critical appraisal mostly. So critical appraisal of a therapy paper, diagnostic paper, prognostic paper, meta-analysis, guidelines, clinical practice guidelines, and then these prediction scores and all that. In medical education, there is a lot of heterogeneity. So many kinds of papers come. So critical appraisal framework is not very well developed in medical education. So when it really develops, you are right. We do it, and we, from postgraduates, we expect that when they make journal club, they have to do critical appraisal. But we have to provide critical appraisal worksheet for them, and the questions which are, or the scales which are available for doing critical appraisal. In medical education, it's not very well developed. Why don't you look for some scales which are there for critical appraisal in medical education?
Yeah, I'll try, sir.
Yes, you will not find many. Maybe a couple may have tried to do this, mainly for assessment of some kinds. But that is one area which can be developed, because it's not yet very mature, as far as I know. But you are right. When we ask for journal club by postgraduates, there has to be critical appraisal along with presentation. But because rules are very well set, we know that there should be randomization, it should be concealment, there should be blinding, there should be complete follow-up, there should be intention to treat analysis, and so on. That is not so well developed in medical education.
Yes, sir.
So there's a variety of articles. Some are named as perspective, some are as viewpoint only, some are reviews.
Yes, yes. Variety of papers are there. But yes, whenever possible, if scales are available, yes, we should do it. But journal club has very many purposes. Sometimes for postgraduates, what you have said is right, that is a vehicle for teaching critical appraisal. But sometimes even in postgraduate, we say that you should have something called exercise in informing what is recent. So some institutions, they have 4 or 5 papers or a journal of a month, and all the papers which are there you have to briefly summarize. So there the proper purpose is sharing information, that's all. So there can be very different kinds of journal clubs, but the main one is where we teach critical appraisal, right? Any other question?
Performance. Excuse me, sir. Sir, in performance assessment, the scenario in India is, sir, something different, sir.
Yes.
For undergraduate, we have to assess ethics, communication and moral values also. So I think it is
Yeah.
different from USA for undergraduate.
No, that part they are also assessing. That interpersonal and communication skills, I told you, is one of the fundamental requirement of competency-based medical education. So that will be, in any case, integral to the assessment. But other assessment, basically, their clinical skills, their what is called practice-based learning and improvement skills. Those are something which are already being done. But you are right that there will be interpersonal communication skills, what they call system-based practice, which is more like quality improvement plan. All those things are to be assessed. They are assessing it in residency program. They have got to assess, otherwise their program will be derecognized. How well they do it, that is open question. And many, as I told you, many program directors are still struggling. So don't think that in US also there is uniformity and a kind of you can say maturity of how to do it. Still struggle is ongoing. I used to go to McMaster University every year to teach in a workshop, which was how to teach evidence-based practice. And I will get residents, particularly chief residents, some faculty, they will come and say, we have come here to learn so that we can implement this competency in residency, which is a requirement by this GMC. So I used to ask them how easy it is, how difficult it is. So it's not yet implemented in letter and spirit to the extent which GMC wants. But everybody is learning, so we have to also. They publish a lot of papers on anything. Any other question? So if no question, then thank you very much, Dr. Archana.
Thank you,
So,
sir.
Dr. Sandhya, you said you will present this, not
Yes,
dental club, but
Thank
about how to frame multiple choice questions. Na?
yes, sir. I will try to do it in this week only, sir. Coming week only.
Okay. That's not the monthly thing, huh? That is a separate.
Yes, sir.
So
That is-
next time, who will do it? Let us have somebody
I will
who.
do. Sir, I
Okay,
will do the
right.
next time.
Okay, very good, very good. Thank you.
you, sir.
Thank you very much.
Thank
Good.
you, sir, for a very good start. And thank you, Archana. And congratulations for a very good presentation. Wonderful presentation.
21st,
Yes.
2022 will be a landmark day for the history of RIMS because this was the first event, Journal Club of Medical Education Unit. And so it is because
Yeah. Once we are doing it well, we can even inform other institutions to join, from
Yes,
Jharkhand
sir.
Yes, sir.
as well as outside Jharkhand.
sir.
So let us do it 3-4 times when it becomes very mature and I think presentable to others, then we will ask other institutions also. But it was a very good start. So congratulations,
Sir, even-
Dr. Archana.
Sir, Hazaribagh Medical College is attached with us, sir, and we are trying to attach some other medical also. They are also listening our program.
Yes, sir. I have joined.
Oh, okay.
I have
Okay.
joined
Very
from
good.
Yes, yes,
Hazaribagh
sir.
Medical College, sir. Dr. A.K. Vishwas.
Acha, very good, Dr. Vishwas. That's. I'm happy to know that Hazaribagh has joined. Good.
today Dr. Umar
Sir,
Shankar
I-
Yes, sir. Myself joined.
sir.
And it is very useful, sir. It is very useful. other institutions also get with this type of program.
Yes, right. Excellent.